All right, perfect. So my name is Emma. I am a fourth-year medical student. I'm currently applying to residency right now. So those of you that are applying to medical school right now, I'm feeling your pain right now. Though I kind of enjoy the process, so I guess I'm an exception. But tonight, we will be talking about our good friend, the aorta. There's quite a few pathologies with the aorta that we want to catch because they're so severe. So we will be talking about that. Because of the feedback I had gotten last time, I decided to do a case series like we did with the infectious disease cases. So we have 4 cases tonight. So I'm hoping to get through all 4. If you're new with us, welcome. I did put the link in the chat. Here it is again. Sorry, here it is again. In order to access all of the resources for tonight, including the SOAP note, in order to get the certificate for attendance. Since there is 4 cases, choose one. If you want to do the first one to write up and then kick back with your feet up later, be my guest. As always, I want you guys to certainly shout out answers, participate, tell me funny jokes, whatever you have. We'll try to keep it lighthearted and fairly simple for you guys, so you're not overwhelmed, and try to have some fun in the process. So without further ado, as you can imagine, if you know me by now, I literally laughed out loud at this. I was like, I have to put this into the presentation. But I'm for the one on the left. I think the one on the right, it just, why would you be wearing 2 pairs of pants is my question. So I don't know what you guys think. I'm for the aorta on the left, the bigger pants instead of the 2 pants. But I do, yeah, the left is more efficient. Yeah, I say left too. I'm with you guys. Is there any people that think the right is better? This is like a left Twix, right Twix situation. All right, so I do have a pre and post poll for you. I'm going to launch it right now for you. There's a few of you out there. Ignore the fact that it says infectious disease. I guess it didn't save when I edited it. This should say, how much do you know about the aorta? Yeah, that's true. It's like conjoined twins. All right. So most of you guys are in there. Let's end the poll. Probably the simplest question I'll ask you tonight. So let's share this. So we have a little bit of kind of scattered out. The vast majority of you guys said you know a little, which is great. And I bet I can probably bet that you guys know a few of these cases that I'm going to present, just because they're so serious and they're emergencies. So we're going to go through those, the can't miss cases, and dissect those. All right, so let's get started here. As always, we're going to go through a few cases. Instead of 1 case, I'm going to split it up into 4 to get more coverage of these things, as opposed to talking about one thing. In between, we're going to go case and then discussion about the pathology or the physiology or whatever is pertinent to the case. So we're going to do like case, lesson, case, lesson, case, lesson. So if you have any questions throughout the entire presentation itself, feel free to unmute yourself. You can do that or type them in the chat. Either way is great with me. And please fill out that SOAP note so you can get credit for this and submit it. Quizzes are now due the next Tuesday. So if you are watching this later on, keep in mind that it will be due the Tuesday after this. So next Tuesday, whatever that date is. I'm bad with dates. But always actively participate. There's no dumb answers. I was always that person that was like nervous to say things in a group, but that's medicine. If you say something wrong, that's fine. I've said 1,000 wrong things. So feel free to speak up and say your opinion. We'll talk about it. We'll talk about why it's right or why it's wrong. And I really want to cultivate a learning environment in these, of which is not judgmental at all. I know that pre-med can feel like everybody's very competitive, but we're going to leave that aside for these sessions. All right, so here's the little snippet of the SOAP note. So what we're going to do, and if you're new, we're going to do in a SOAP format. So SOAP is an acronym for subjective, objective, and then assessment and plan. In the subjective, we're going to put things that the patient tells us. So history of present illness, so things that the patient's telling us about their symptoms or their ailment. The review of systems is going to be pertinent positives or negatives pertinent to their chief complaint, while objectives is things that we find, like our vital signs, like our physical exam. And then assessment, we're going to assess the patient and put down what we think is going on with the patient. And then we are going to make a plan for what we're going to do for that patient based on how they're presenting, okay? So fairly simple, do it to the best of your ability. This is gonna give you a little bit of practice and exposure to the SOAP format, because you will be writing like this in medical school, and it's nice to have a little bit of exposure to it in advance. So don't get stressed out by it. Nobody's sitting on the side of these and grading them and being like, wow, shouldn't have put that. It's just for your practice, really, okay? All right, so when we talk about the aorta, we're going to do a brief little introduction. There's tons of pathology, and this is a list, that I found that just shows, a few of them. Some of these things, you look at them and you're like, wow, that's probably serious. Like this kind of trio right here, that's, certainly important. We can talk about things like aortic enteric fistulas, where you get kind of a passageway between the bowel and the aorta after surgery. That's certainly bad as well. Coarctation, where you get stenosis of the aorta, that's more of a congenital condition. And then there's other things that we're talking about here, like Marfan syndrome, Ehlers-Danlos syndrome, that can, affect different pathologies, can lead to things like aneurysm or dissections or other stuff. And then a couple things that are different arteritis conditions as well. So, and then things like trauma can certainly, impact the aorta, but there's lots of different pathologies with the aorta. And as we know, or may not know, the aorta is a big kind of tube that goes from the heart that carries lots of blood. So we think the aorta is sacred, and we don't want to mess with the aorta. So if you remember anything from this presentation tonight, it's that we don't want to mess with the aorta or the pancreas. All right, so let's talk a little bit of anatomy here. We're going to keep it simple. I didn't want to just show you this arteriogram without giving you a little bit of a cartoon that shows, the actual anatomy. So when we talk about anatomy of the aorta, we want to talk about the great vessels that come off of the aorta. The first of which is the right subclavian artery. So we see that's our first friend that really comes off. So here, what we're seeing is the aortic valve. So we know that the heart would be, right here. And this is obviously accurate, my heart. That's exactly what your heart looks like. So the right subclavian artery is the first one that comes off, yes. And we find that it's not exactly symmetric with the other side. We see that our friend, the right common carotid, which goes up to your neck and delivers vasculature to your brain and your face. We see that the right subclavian goes off this way and supplies your arm. Okay, great. And then your right common carotid branches up and then goes to your face, as we kind of just talked about. Then on the other side, the left common carotid doesn't have a branch off point from the left subclavian. It comes directly off the aorta. That's what this branch is here. Okay, so and then the next one that we talk about is the left subclavian that supplies blood to your left hand. Okay, and then the aorta, a huge tube, you can see it here, and then it splits down into the iliacs. That's what we're wearing pants in the cartoon that I showed you before. And then we have obviously some vessels that come off the aorta here that are important. This is the celiac artery that supplies your foregut structures in your abdomen. Then we have the superior mesenteric artery that supplies some more of your gastrointestinal system. And then we have the inferior mesenteric artery here. Okay, and then we have other things that come off here, like the renal arteries. That's kind of what you're seeing here. And then we have some like the gonadal arteries and different things like that. Okay, so that's inferior mesenteric artery. All right, so now we're going to do take a look over at the drawing on the, not the drawing, the arteriogram on the right here. So I'm going to ask you a few questions, and I want you guys to use the cartoon that we just went over to try to answer these things. Okay, so let's start with here. And when one last thing before we kind of go over there, remember that this part kind of coming up here off the heart, it makes sense. This is the ascending aorta and then descending aorta as it kind of goes down. Okay, so right here, I just put a stamp on it. What are we looking at right there? What is the first vessel that comes off? Is this the right side of the patient? Yeah, so we're looking at them, and their left side is their left is our right. So they're facing us, okay? So the first one that's coming off, yeah. So what we're looking at here is, you're right, yeah. We're looking at the right subclavian, which is going to give rise to, what is this structure over here? Going to the arm. That's right, it's the right subclavian, perfect. And then what about these structures here that are going up to the head? Perfect, they're the common carotids, excellent. And then what about over here on the left-hand side here? Gives it away. The left subclavian, good. And that's the main thing. It's as simple as that. The anatomy for the aorta, there's lots of branches, but we're going to focus on the great vessels here for all intents and purposes tonight. All right, so great job. You guys are off to a great start. And I'm putting stamps all over the PowerPoint. All right, let's keep it moving here. Apparently, I want to just put stamps. All right. See if I can, it's not wanting to get rid of the stamp. Did that all week, yeah. That's me tonight, I guess. Okay, there we go. All right, so now we're going to talk a little about, in rather superficial detail, admittedly, a little bit about the physiology. But when we talk about different things here on the aorta and on the vasculature, based on the structure, based on the diameter, there's different functions. Okay, so the aorta itself, we see that it's for distribution and pulse dampening. So we know that the aorta itself is very thick walled because it's handling a high amount of pressure being pumped out of the heart. Otherwise, we talk about arteries, we talk about the other side, the big vessel on the other side, that's the vena cava. And this is for distribution as well. And it collects blood. But otherwise, when we talk about these smaller vessels, we talk about things like exchange. And that's what we talk about the capillaries here. And if you remember from the times that we talked about pulmonary vasculature, we're talking about exchange of nutrients, blood, oxygen, things that the lungs need as well. So this is just a very superficial outlook of the physiology itself, but no, based on the structure, structure kind of affects the function. So, and that's an important thing to remember in medicine, because when we get down to smaller things, we're talking more about resistance and distribution than things like exchange when we get down to the capillary level, which are very, very small. All right, so let's keep going here. All right, and then when we're talking about pressure, as we kind of have these big vessels like the aorta, they deal with more. The aorta undoubtedly deals with higher pressure than things like the vena cava and the veins and the venules and the capillaries. So we see that kind of drop off there. And I think this is a good kind of a representation of that. All right, so without further ado, let's get started. Let's have somebody out there. I'm gonna rest my voice. Somebody read the case for us, please. Don't be shy. Somebody out there.
I'll start us off today. Woohoo! All right, so a 29-year-old male presents emergently after high-speed MVA. Witnesses state that the patient was traveling approximately 60 miles per hour when he collided with a concrete barrier after losing control of the wheel. The patient is short of breath, pale, hypertensive, and tachycardic, as well as complaints of tearing chest pain radiating to the back.
All right, so thank you, Stephanie. What tests do we want to order? And does anybody have any ideas in terms of tests to order, labs to order? And we'll talk about the diagnosis in a minute. We'll put together a differential based on what tests we order. So ideas, anybody? What do we want to order? A chest x-ray? Okay, sure. MRI. That's a good idea. We can certainly think about imaging. What about something at, when someone's in a it's a cheap test. Also, it is fairly quickly, and we can do it at the bedside. Especially good, yeah, an ultrasound. Especially if someone has high-level trauma, we want to get it done quickly. So Stephanie wants an ultrasound. So here we go. The radiologist put an arrow and they put a star. So we'll say that the star, yeah, look for an increased JVP. Yeah, exactly. We can look for different signs of vascular things going on, certainly. And yes, we certainly want to examine this person, and we can start with this ultrasound. Okay, so the star here is showing the actual lumen of the actual aorta. Okay, so what is the arrow showing? So we see kind of this line here, and then we see what looks like another lumen. So what's going on? There's something there, yes. So there's blood where it shouldn't be, okay? So does anybody have any ideas of what this is? So high-speed trauma, we know that the aorta is kind of tethered by what's called the ligamentum arteriosum. It's like basically like a thread that's holding on the aorta. So when we have this shear trauma, this acceleration and then sudden deceleration, the aorta is at risk for trauma. So what may have happened here as a result of this person's high-speed trauma? Certainly we can consider cardiac tamponade. I'm thinking about the aorta specifically, our friend the aorta. So did it collapse inside of something? So let's talk about this. This is an aortic dissection, okay? So this is something that's terribly important to remember. And if we look back at this patient presented pretty typically. And you'll see, you guys that are scribes out there, sometimes you'll see the attending or whoever you're scribing for, sometimes they'll order an ultrasound or a chest x-ray, as you kind of alluded to. Harley, you talked about a chest x-ray. That's certainly something to order, and we'll see a widened mediastinum. The chest will kind of look wide. And we talked about a widened mediastinum when we talked about congestive heart failure, but this person had tearing chest pain that's radiating to the back, and that's pretty typical for this, so we don't want to miss it. The other thing that we may see is asymmetric pulses from one side to the other, okay? Because why might we see something like asymmetric pulses? Think about the anatomy that we just talked about. Why would we see that? Yeah, unequal blood flow. So if basically what's happening with the aortic dissection is we have a tearing of what's called the tunica intima. And if you look at this picture down here in the bottom right-hand corner, here's the intima. It's this layer, there's 3 layers of the vessel. There we have the intima, the media, and the externa, which I love when things in medicine just make sense. The media is in the middle, the externa is on the outside. Perfect, because a lot of things in medicine sometimes don't make a lot of sense, the way they're named or what have you. So this one does make sense, luckily. So we get a tearing here in the intima. So here's our tear, and what's happening is the blood is rushing through here and causing a false lumen. Okay, so we see blood on this side, and this is where our blood should be, in the middle of the vessel. So in this picture over here, this is where our blood should be, and then we see a false lumen in here. So let's go back to that ultrasound here and see if that doesn't make a little more sense to you guys. Does that make more sense in terms of what's going on in this ultrasound now? Perfect, great, and that's my goal for you. I didn't expect you guys to recognize an aortic dissection, but I hope you do now. So there we go, that's what we're talking about. We're talking about a false lumen being formed here, okay? And the things that can be a risk factor for this is things like hypertension, atherosclerosis, so having plaque in your arteries, a AAA, things like an aortic valve defect, like either aortic stenosis or regurgitation, an unequalization of pressures in the heart chambers. We talked a little bit about coarctation, so that alters the pressures as well. And then things that are genetic, like Marfan syndrome or connective tissue diseases. So things that are going on with the actual vasculature and altering the either elastic membranes or the collagen in the artery itself. Okay, and then another genetic disease, Turner's syndrome. Okay, so on exam, don't miss this one, asymmetric pulses. If you see asymmetric pulses, you want to think one of 2 things, okay? You want to think aortic dissection, which is what we're talking about now, or an aortic aneurysm. So neither of those things you really want to miss. You can see neurologic deficits. As you can imagine, if blood is in this false lumen and not going to our carotids, those big vessels that go up to the brain, then yeah, sure, we can have neurologic deficits because we know that the carotids supply blood to the circle Willis in your brain and perfuse your brain so that you can think. So we have 2 types of aortic dissections. We have type A and we have type B. This one is fairly simple. So type A is an ascending is in the ascending aorta. So, you know, this part that's going up, and then type B is the descending aorta. And it's important to identify those because we treat them differently. Ascending dissections, type A dissections, those usually require more aggressive treatment like surgery, because it can affect the valve here, the aortic valve, and cause regurgitation, which can be detrimental to the heart and cause heart failure. Okay, and then descending, usually we treat those medically with beta blockers and other medical interventions. Okay, and then we're going to talk very briefly about the treatment here. It's called TVAR. It's thoracic endovascular aortic repair. And basically what is going on here is you'll see in this video here, I just want to show you briefly, if it loads. Oh, great, it's failing me. We'll see if it loads here in a second, but it's basically what we're doing there. Okay, great. So it's showing you the branches here, and what I want to really show you is the part here. So we see those branches that we just talked about. So we should see some familiar things, those great vessels. But when we have that dissection, we want to make sure the blood goes in the actual aorta and not in this false lumen. So what we're doing is taking a graft and going up through the groin and placing it in the aorta to prevent that blood from traveling in that false lumen. Okay, so as we just see in this flow chart here, we manage type A and type B dissections a little bit differently. Okay. So let's keep going here. So case 2, if anyone has questions about case 1, let me know. We're moving pretty quickly here so we can get through a few different things about the aorta. But if you have any questions, please ask. All right, somebody else, please read for us this very short vignette.
I'll go. A 66-year-old male presents to the clinic with a 1-month history of pain in his legs when walking. He notes that he can walk short distances, but often needs to stop to rest. He is a lifetime smoker, 1 pack per day for 51 years. Yes.
Awesome. Thank you very much. I appreciate it. So what do we want to order for this patient? Does anybody have any ideas? He has pain when he's walking. What differential diagnosis do we want to consider? He's a smoker. What do we want to think about here? You guys can be broad. You don't have to think aorta for this one. I want your differentials to be good. So chest CT, lung cancer, good. Yeah. Blood clots, yes, great. We want to think blood clots if someone has pain, especially if it's unilaterally or they have a swollen leg. COPD, absolutely, because if someone is smoking if they're a career smoker, then we want to consider something like COPD. Thrombosis, absolutely, good. And what tests for this? So you guys are saying blood clots, you guys are saying COPD. What tests do we want to order for this gentleman? Any ideas? Chest x-ray, absolutely. We can get a chest x-ray on this guy. Anything else? We can get a D-dimer, absolutely. Yes, a D-dimer is non-specific, but it will tell us if there's fibrin split products in the bloodstream. What about for his pain with his legs? If we're thinking a blood clot or whatever else, what do we want to get? Yeah, a Doppler ultrasound, good. So Liz wants a Doppler ultrasound. We got an ultrasound, and we got one of the aorta, our friend the aorta, due to his history of smoking. Okay, so what I want to point out to you here, and somebody also has done this with their arrows, is here's the lumen of the aorta. And then something's going on here. Here's another lumen. Okay, so what's going on here? This looks similar to our last picture, but what do you guys think is going on here? When you think, okay, history of smoking, what if I told you he had asymmetric pulses? What are we thinking about at that point? Aneurysm, good. Yeah, we want to think about an aneurysm for sure. Because he has a history of smoking, and you guys are all right on with that pain in his legs with walking. And I made this case a little bit ambiguous for a certain reason, because I want to show you something that's kind of cool in the end, and it's cool when you get to see one of these surgeries. So here's his lower extremity Doppler. It's normal, shows normal flow, and that's about the extent I'm going to get in with that. Okay, so here's the pathology of this, and I want you to listen to this briefly, and I hope you can hear it. Are you guys actually able to hear that? I actually couldn't hear it myself, but it's a bruit, and I encourage you to look it up later. Look up bruits. It's kind of like a swooshing sound, and that's what you can hear when you auscultate the abdomen sometimes when the patient does have an aneurysm. All right, so what we're talking about here, sound share that helps with audio videos. I'll let you guys get that on your own. Yeah, next time. That's probably what I didn't do. Usually I turn off all the sound because I talk over them, but I probably didn't do that. Stephanie's like my IT department for this call. But what we see for the pathology for this one is, we remember our friend in the middle of the artery, the tunica media. What we're seeing is a degeneration of that. So, you know, an aneurysm is exactly what it sounds like. We see, you know, here's the aorta and all of a sudden it's ballooning out like that. You know, we can see aneurysms in any vessel. It's true, any high pressure artery usually, but it's most deadly in the aorta. As you can imagine, there's tons of blood. And if, you know, it gets big enough or ruptures, that can kill someone. So we want to be able to catch these things. And, you know, things that lead to it is things that this patient had: smoking, a little bit older patient, history of atherosclerosis, and probably vascular disease too, really, with that history, long history of smoking. Sometimes we feel a pulsatile mass. That's concerning. We can hear an abdominal bruit, which is just a swishing sound. It's pretty distinct. You won't miss that one, trust me. And then the other thing is, these are often asymptomatic, and for that reason, the USPSTF, say that 5 times fast, they recommend, and this is the like a preventative task force that puts in guidelines for screening. So they're the people that recommend, you know, pap smears every 3 years for women who are under 30, and all these different guidelines that physicians follow. Okay, one of them that they recommend, which it's a grade B, which is you know, almost the highest you can get. A is as you can imagine the highest. They recommend a one-time screening with an ultrasound for patients 65 to 75 who have ever smoked. And there is another one for patients of whom are smokers as well, for lung cancer. That's a low dose CT scan. So whoever said that was absolutely right as well. We can get a low dose CT scan for people of whom have a high smoking history. So that's why we got that ultrasound, and that's why we screen for it, okay? So we can diagnose this with ultrasound, CT, MRI, so you guys were right on point with that. And our treatment options for this are observation, if it's small, but if it's less, or if it's greater than 5.6, that's when we want to intervene. We want to do something about that to prevent the risk of rupture, because as it's smaller, we know that the risk is not as high. Okay, so all right, and then there's some things about how to describe them here. I thought it was cool that they had the ultrasounds kind of next door to them. So that's, you know, what ultrasound, or what the different aneurysms can look like based on the you know, the ultrasound image. So it's less important to really name them, but that's there for your kind of benefit. So here we go. Let's keep it going here. All right, so we're off to case 3. That was a pretty quick one. So those are probably the 2 most important ones that I'm going to teach you tonight. If you know, catch those things, you can really save somebody's life, especially with those asymmetric pulses. Okay. All right. So a new person, please, or the same person, doesn't matter. Let's have somebody read this next case for us. Anyone? I don't want to call out a name. I don't want to be that person. Somebody read this one for me.
I can go again.
I appreciate you.
A 66-year-old male with a past medical history of hyperlipidemia, hypertension, and diabetes presents for a 3-month history of lower extremity pain when walking. He notes he used to walk his dog about 2 to 3 miles a day, though now he is only able to walk about a block before needing to stop to rest because of the pain. The pain is described as cramping, and he also notes that his legs are often cold.
Thank you very much. Okay, so we have an image here, and obviously this is my hand right here. I'm just kidding. I found this on the internet. That's not even my hand. But we see the patient's leg here, and we see that it doesn't look good. Okay, this is what we call stasis dermatitis. Okay, and that is what we see is because of either primarily because of venous insufficiency. But when we start to see cold extremities and you know, pain with walking, we start to think more of the arterial side. Does anybody know what that's called? Specifically what the pathology is called? Look at the kind of history. They have a history of hyperlipidemia, hypertension, diabetes. So we want to think about things for atherosclerosis. Okay, so he gets lower extremity pain when walking. Okay, so we want to think about the arterial side. All right, and he used to walk, and now he needs to stop to rest. He's getting cramping. Okay, so what test do we want to order here, my friends? Any ideas? We can definitely order a Doppler. Sure. Yeah, good, Liz. Great. She's well versed in the ankle brachial index. Perfect. And that's what I would order here too. The ankle brachial index is the gold standard for peripheral arterial disease. And that's what we're talking about. When we talk about problems with the circulation in the extremities, we want to delineate whether it's venous or arterial. Overwhelmingly, usually it's due to venous incompetence, venous insufficiency, where we know that the veins going back up to the heart have valves. When those when the valves get stretchy and lazy, so usually it, you know, looks something like this, where we have these valves like this that kind of cross up. And then when, you know, our very defined calves, they contract, because we all work out, we all have time for that. When they contract, the blood goes back up and these valves close. And we see when people have venous insufficiency for a multitude of reasons, what we see is, you know, we see these incompetent valves where maybe they aren't closing properly. So the blood, yes, is going down because gravity works going down. And then what we see is that the blood is able to go up, but also back down. So we have this problem with competence of the valve. So that's why we call it venous incompetence. We call it venous insufficiency. Okay, so the other side of that is peripheral arterial disease. And we see this problem, you know, where people have risk factors for atherosclerosis, so plaque deposition in the arteries or in the aorta, for instance. We see that they're not able to get blood flow. As you can imagine, if we have this artery and then, you know, we have risk factors for plaque deposition, guess what is not going to get through there? I bet you guys can guess this one too. We're going to see this plaque because they, you know, people eat too much Whataburger or whatever. I'm not bashing on Whataburger. I like Whataburger. It's great. but in moderation. So what we see here is, we see turbulent blood flow, and that's a problem because we're not able to get as much blood flow. We see here, we can't really get through. Here, we're able to get through. So we get turbulence that sets us up for blood clots. It sets us up for peripheral arterial disease, where we get problems with circulation to the lower extremities. Okay, so that's the big deal here. So we ordered some tests. Okay, great. What did we order? We ordered an ultrasound, like Harley said, which I like your name. That is an excellent name. I have a Harley. So were you named after the motorcycle, Harley, or is it just not associated with the motorcycle?
Yeah, I was. My parents like rode a Harley like across the country when they were young.
Oh, that's awesome. I love that. Okay, well, back on topic. Here we are seeing something very reminiscent of the cartoon that I just drew. What is this? It's a plaque. Yeah, exactly. It's an atherosclerotic plaque. And so we see plaque formation when people have those risk factors. So great. And this is, the same thing. Blood is not able to get through here. We get turbulence. It sets us up for blood clots, sets us up for decreased flow and increased risk of ulcers, increased risk of peripheral arterial disease. So perfect. Let's go on and let's talk about the pathology of peripheral arterial disease here for a second. So what we see is what sets us up for that is hyperlipidemia, okay? And we see that atherosclerotic plaque formation. As we kind of talked about, we can see abnormal lower extremity pulses. If we're not getting blood down there, we might see, decreased dorsalis pedis pulse or posterior tibial pulse, okay? We might see mottled skin. We might see ulcerations. I literally saw a patient today in dermatology of whom had this problem, had venous insufficiency and maybe arterial disease, and has poor wound healing. So these things happen, you're gonna see it. And because the blood is not getting down there and not oxygenating, and it's, forming necrotic tissue, sometimes it gets infected. And that's a problem because it gets infected. We treat it with antibiotics, but it heals very slowly and it's a pain, literally. But as Liz mentioned, the gold standard is the ankle brachial index. And you're probably like, what does that mean? What we do is we take the blood pressure, the brachial blood pressure, so the normal blood pressure, and then we take the blood pressure at the ankle and we compare that. It's an index. So it's a comparison of one value to the other. If it's less than 0.90, we say that's concerning for peripheral arterial disease. Okay, that's really all. We can do a Doppler as well to see what the flow is like arterially as well as in the venous system. But that's as simple as it gets. This is very common. You're going to see it, and hopefully, if you guys are scribes or out there and you see it, you know a little bit more about it at this point. For treatment, we have a few options. We could do medical management here, and often a lot of times this is treated medically first before we intervene with things like surgery or revascularization. Okay, so that's really yeah, you see it a lot in ortho, that's right. And surgery, you see it often too, especially vascular surgery. And that leads me to my next slide is, yes, there's lots of ways to fix this. We can do statin therapies to lower the cholesterol. We can tell them to stop smoking and help them with smoking cessation, lifestyle modifications, different things like exercise to revascularize. But what we see here, and sometimes if the blockage is up proximally, so proximal meaning higher up instead of distal, what we see, and something it's super cool. I got to see one of these surgeries and scrub in on a surgery like this, which is awesome. And what we see is, if we have a blockage, and it's showing this extent of this blockage here in yellow, and I shouldn't draw over it so you guys can see it, but here's the blockage in this cartoon, and they put it in yellow like I would imagine. I think that's perfect. That's how I imagine plaque looks. And it really does actually look like that's kind of gross. But here's the blockage, and what we do is we get a graft, and it's a synthetic graft that prevents clots and is similar to the vasculature of the aorta. And what we do, this is an aorta bifemoral bypass surgery. Also say that one 5 times fast. But what we're doing is we're taking, proximal to the blockage, and then we're allowing blood to bypass that. So what we're doing is allowing blood to come out this way and then get down to the lower extremities. So as you can imagine, if the problem is here, we're just bypassing that. Otherwise, there's a little cartoon over here that shows we can do intravascular things like a balloon, or we can do stents as well. The balloon has kind of fallen out of favor in some circumstances, because what we're doing here is we're taking the balloon, like in the heart. I'm sure you've heard of it in the heart. And I think Jackie's taught you things about the heart. But what we see in the heart, especially with people who were revascularizing for MIs, what you're doing is you're taking that balloon in, and exactly how you would imagine a balloon is, you're puffing it up and then pushing the plaque out towards the periphery. So you do have a chance of that plaque reaccumulating. So that's kind of the problem with that one. It's, more of a temporizing solution than anything. Okay. So, and then when we talk about stents, there's other considerations like anticoagulating people and whether it's a bare metal stent and things like drug-eluting stents, where they elute things that prevent embolization and prevent clots. All right. So, oh, my arrow is still there. Let me get rid of that. Awesome. So let's keep going here. Here's the last case. I'm actually moving pretty swiftly. I hope you guys notice that. I might get you out of here on time. So let's see. Last case. Let's have somebody read it. This one is actually my favorite case. So let's keep going here.
I'll do this one. A 31-year-old female from Tokyo presents with dizziness, fatigue, cold feeling hands, and headache 3 times a month. She notes that these symptoms are often worsened by exercise. On examination, there is a discrepancy in blood pressure from left to right without palpable pulses. ESR and CRP are elevated. Additional tests.
Awesome. So, any ideas, anybody, what tests you guys want to get? There's one obviously shown here to the left because I didn't put in the animation correctly for the slide, but what else do you guys want? We're not going to jump just to an angiogram here. What else would you guys consider getting? So she has some neurological symptoms. So what else would we want to consider in that regard? So we know if she has neurological symptoms, it could be from a number of things, right? It could be from a primary pathology in the head. We can get some labs, sure, head CT, excellent. We know that if there's neurological problems, it could be in the brain, it could be due to vasculature. The patient could be having a stroke. She's certainly young for a stroke, but maybe she's hypercoagulable. These are things that we want to consider. A stress test, sure. She has decreased pulses in her hands, and she feels like her hands are cold and she's fatigued. So we want to think things along the line of what? So fatigue, cold feeling, dizziness, just general malaise and lethargy. We talked about a little bit of fatigue before. What do we want to think about in terms of endocrine? close. You can think of, kidney can certainly cause malaise too. Congestive heart failure can. I'm thinking of one specific endocrine thing that causes fatigue, weight gain, what else? Just general malaise, difficulty thinking, depression. Thank you. Yes, your thyroid. I was gonna say it starts with a T and rhymes with thyroid, but that would have given it away. So yes, thank you. It is the thyroid. You're absolutely right. So we can throw on some labs for that. But we'll take a look at this angiogram over here. So at one point we decided, all right, this is a vascular problem. Let's go ahead and work that up. What are we seeing here? We're seeing, okay, it looks like a normal right subclavian. We see a good right common carotid. We see a little bit of issues here. What's going on here? Here, and then we see some beating there. What does that look like to you? It looks not normal, but what does it kind of look like? It looks like what Homer does to Bart. Yeah, sure, it certainly does. But we see, you know, it looks like there's stenosis in this vessel, right? And we took a biopsy of the vessel and we saw something like this. And we talked a little bit about histology. Histology can be hard, okay? But what we're seeing here is we're seeing formation of inflammatory cells and what looks like perhaps an autoimmune process. Because what we're seeing is here is maybe the formation of a granuloma. We see around it a ring of lymphocytes, epithelioid cells, and a little bit of giant cells there in the middle. There's, you know, plenty of inflammatory cells here. So and the beating that I'm really talking about is like here and a little bit. Oh, turn that arrow around. Oh no, now it's going in a bad direction. Okay, right there. But you kind of see that beating, which suggests to us that there's stenosis here going on. Okay, does anyone know what this is called? I don't really anticipate that you'll know it, but if you do, then you've earned my gold star for the evening. It is an arteritis, and it's very common in Asian women. That's as you can kind of see in the vignette. Yeah, it is actually a Japanese name. It's called I actually like saying it. Let me show you so you can see how it's spelled too. It's called Takayasu arteritis. So it's one of my favorites. It's fairly rare. It's an autoimmune condition, and what we see is it's a vasculitis. So it's an autoimmune thing that affects the great vessels, okay? And when we see that, we saw that over here on the left subclavian. And as I kind of mentioned to you, it's common in Asian women who are less than 40. So that was exactly what we saw here. And the other name for this, because we have to have like 17 names for everything in medicine, is pulseless disease. So remember, when we see asymmetric pulses, we want to think about something like aortic dissection or aortic aneurysm. But when we see lack of pulses on one side altogether, okay, that might tip us in the direction of something like a vasculitis, okay, or a differential in the blood pressure from one upper extremity to the other, okay. Is this a presentation similar to Raynaud's? Kind of, and when you think of that, yes, you can think of Raynaud's. Raynaud's, you'll kind of see on the hands the red, white, and blue, where you know it's kind of white, and then you see a little bit of blue, and then you'll see it red where the hand is actually being perfused. And that's due to another pathology, which we can talk about autoimmune things all day. You know, people can certainly put Raynaud's in their differential. And by the way, when you have one autoimmune thing, you want to think of other things as well. So it is very similar to that and scleroderma. All right, so we diagnose this by a biopsy, and we can use a CT or an MRA angiogram we talked about, and this is treated with steroids, okay? All righty, so any questions about that one at all, or any of the other cases? They're pretty quick and you know, pretty brief, but I wanted you to get lots of exposure to different things from the aorta. All right, so here's kind of a, you know, just a review for you all in terms of the aorta, and I want to, you know, emphasize a few things about the anatomy again. Obviously, here's our ascending aorta. We talk about our arch, and we talk about the right subclavian, which gives rise to the right common carotid. Here's the left common carotid here, and then here's the left subclavian, okay? And we know that those go to our extremities. When we talk about our pathologies in terms of the dissection, we can talk about a type A that happens in the ascending aorta, which affects, you know, our friendly neighborhood aortic valve right here. And then, or we can talk about a type B, which happens in the descending. And that's important because they're treated differently, okay? Otherwise, in people of whom have risk factors like smoking or atherosclerosis, we can think of something like an aneurysm. And that's important because like a dissection, that can rupture and cause problems for the patient, and it can kill someone very rapidly, okay? Otherwise, we can think of things when we get, you know, plaque in the aorta or in the distal extremities. We can think of things like peripheral arterial disease. And then if we get that autoimmune sclerosis, where you see that beating and that formation of inflammatory cells, we can see something like Takayasu's arteritis. There's another one, it's called giant cell arteritis, that affects the temporal artery. You'll see that one, similar kind of autoimmune pathology behind it, but people have like jaw pain when they chew. And that's another arteritis, not so much aorta, it's, you know, more the temporal artery up here. All right, and I wanted to show you this cartoon, and we talked a little bit about this when, you know, we have problems with, you know, the flow. We like laminar flow, the blood likes laminar flow, and so does the arteries. And when we get this all, you know, messed up, you know, blood flow, it creates chaos, and it sets us up for clots, sets us up for stasis and different things affecting the body and the return of oxygen to the systemic circulation, okay? So that should be it for me. That is it for me. There's my sources. That's all basically images. But that's what I have. Remember to do your quiz so that you can get some credit for this and you can put that on your application later. I think it would be of value for you guys to talk. And I certainly wish I had these whenever I was when I was in undergrad myself. But I am going to stick around here for you know, a few minutes to answer any questions that you guys have. I think this is the first time ever I've ended on time, so take it while you can, and I'll stay around for a little while and answer any questions that you guys have. But as always, thank you so much for your time. I you know, always enjoy doing this. This is always a pleasure and always a highlight of my week. But thank you all for coming, and we'll see you guys next time. Kendrick Laminar, that's hilarious. And that's how you remember things too, by silly things like that. Thank you guys. If you guys have any questions at all, I'll stick around. You can ask me anything about med school or anything. And thanks, Stephanie. I appreciate it.
Sorry, Emma, I had a quick question about the aortic dissection. I'm like kind of fuzzy with the details. So did you say that after a certain diameter, the like if it was it too small? Like I think oh god, okay, hold on. Sorry, let me try to word. Like the value that you mentioned was 5.6 in diameter, correct? Was it millimeters or?
So are you talking aneurysm or are you talking dissection?
I probably was talking aneurysm.
Yeah, so the size that we look for is primarily 5.6 centimeters. And you know, some people use millimeters, but we talk about the centimeters of the diameter. And that's how we kind of gauge. And when it's above that, we say, all right, time to intervene. And otherwise, I didn't want to bore you with all the details because there's, you know, if it's, you know, between 4.5 and 5.4, then you want to follow up every, you know, like 3 months or so with an ultrasound just to monitor to make sure it's not progressing. So based on the size, we do, you know, different interventions. If it's a little bit smaller, we might say, okay, come back in a year and let's take a look with the ultrasound, because there's a different risk in terms of the size based on, you know, studies and evidence-based medicine. So if it's smaller, you have a smaller risk of rupture correspondingly. And if it's larger, we need to intervene pretty quickly, especially if you have uncontrolled hypertension or, you know, other risk factors. Okay.
I just had a quick question. What's the difference between stasis dermatitis and intermittent claudication?
So it's stasis dermatitis is the manifestation of venous insufficiency. When we say intermittent claudication, that's basically that what we see whenever we you get that when you're walking and then you get that cramping pain in your extremities and you have to rest. That comes a little bit more with arterial problems. Not to say you can't get, you know, pain and stuff with venous, but usually venous is kind of quiet and it is usually pretty chronic. So intermittent claudication kind of goes along with that. It's a symptom of which goes along with peripheral arterial disease. And then, you know, the venous side is where we see stasis dermatitis manifesting, kind of those woody changes on the skin. Good question.
So I guess it's just a difference between a pathology and a symptom, but then for different, for the venous system or the arterial system.
That's right. Yeah, exactly. So intermittent claudication is more of like a cute way of saying you like pain when they're walking. So we, you know, would write that in our chart as essentially like a symptom. You're right. Or put that in the ROS. And then stasis dermatitis would be more of an objective finding that we would put in our, you know, our physical exam. So yes, intermittent claudication points us in the direction of arterial, while stasis dermatitis points us in the direction of pretty bad venous insufficiency.
Okay, great. Thank you.
Yes, absolutely.